Hi, my name is April Chen, and I'm a licensed master social worker, and I have a passion in counseling grief clients. So I got further education in it, and there's a certification for those interested in clinical counseling for grief, known as the Certified Grief Informed Professional. And I recommend getting that education if you're going to do grief counseling because it gives you significant education, some counseling hours, and then you sit for an exam. So you learn the things that you need as you work with grief clients, because it is a very specialized area of study, as you will see. So the objectives of today's presentation are the following. So here's what we're going to talk about in this particular presentation. And there are a lot of subtypes of populations that we won't get to today, but we're going to understand the types of grief and the current models of grief. We're going to recognize the signs of what used to be called complicated grief, but now is known as prolonged grief disorder in the DSM-5 TR. So we'll talk about that. We'll learn the very core grief therapy counseling techniques. There's a lot that have branched off from that, right? We'll also explore some cultural considerations. And then lastly, we'll discuss some self-care for grief counselors. That's very important to know because self-care is absolutely imperative to be a good grief counselor. So what is grief? A lot of people have a lot of definitions about what grief is, but it's the normal or natural emotional response or to the loss of someone or something significant. And you might be thinking, well, grief is just when someone dies, right? Well, no, that's not true. People can grieve things that are not people, and we'll get to some of that too. But grief encompasses a large range: physical realms, emotional realms, cognitive realms, behavioral, social, spiritual. That's part of the definition, is that these are the types of reactions to the perceptions of loss. Losses can include things like deaths, like we mentioned, right? It's very common. Divorces, that can be something someone grieves. Maybe their spouse cheated on them and they really wanted the marriage. Well, that can really cause grief, very similar to losing a person, because they did lose a person if you think about it. Job loss, because that's loss of someone's identity. Illness, because people lose function of their abilities. They can't do the same things that they did before. So that's something to know as well. There are multiple models of grief, which we will get into as well. So the first model of grief that we're going to talk about is the dual process model of grief. This model is a kind of an oscillation model, right? So in the middle, you see the everyday life experiences, and it suggests that people kind of move back and forth. They oscillate between two processes, like loss-oriented things, such as dealing directly with the loss, like crying, remembering, yearning, maybe writing about it, and then restoration-oriented processes, which is attending to life's changes, doing new things, distractions from grief, denial or avoidance of grief, new roles, new identities, and new relationships. And this is one of the current models on grief that we use, and it kind of replaced that Kubler-Ross model, which we'll touch on so that you know that does exist. But this one is one that has come to fruition in grief counseling around 1999. And the one before that we used is William Worden's Tasks of Mourning. It was first introduced in 1982. And in the 1990s, in fact, when I first took human life studies, whatever they call that course, the first one that you take when you touch on these psychological and sociological concepts, it was the Kubler-Ross model of grief. And that one had 5 stages of denial, anger, bargaining, acceptance, depression. And I didn't even say them in the right order, but It stated that clients went through denial, anger, bargaining, depression, and then acceptance in a predetermined order. And it was later determined in the 1990s when William Worden and the dual process model by Strobe and Shute came into practice, that people actually don't experience predetermined steps in any particular order. Rather, they experience them in their own time, but the goals are kind of to accept the reality of the loss, to experience the pain of grief, to adjust to life after the loss, and to maintain a connection while embracing the new normal. You can often remember this one. This is a good mnemonic device to remember. William Worden and his tasks of mourning is TEAR. And we use this a lot with clients when we do psychoeducation in grief counseling. The Kubler-Ross model lost its steam for bereaved individuals, but when I was doing clinical work in the hospice setting, we used it to describe patients coming to terms with their own mortality through the terminal diagnosis, or someone losing their functional abilities, because this particular hospice had a palliative division as well. Palliative care is kind of the intermediary before someone goes to hospice care, and it kind of it's where people lose a lot of functional ability. So you'll see chronic illnesses like emphysema, breathing issues, not being able to walk anymore. Some cancers remain palliative while they're getting treatment, and that's a whole another discussion, right? To talk about the differences between hospice and palliative care. But it's a very interesting discussion. So if you want to learn more about that, look it up. The National Hospice Association has all that information. But getting back to the grieving part, which is where most of my clinical work was, most grief counselors and therapists, as I said, shifted away from this Kubler-Ross model, and Worden's model was seen as more flexible, actionable, and you could easily individualize it. So basically it became better for person-centered therapeutic modalities and approaches, which is what we try to do with grief counseling. So the types of grief, there are several different types of grief, and the main types are covered here. And these are some of the signs of grief, right? We called this PINs, a little different. I couldn't find the diagram, can't draw it, but it comes in the form of all these things in all these realms, right? The physical, the emotional, mental, the relational, and the spiritual. And we did the physical, emotional, the mental, and the social, and the spiritual. That's what PIMS kind of stood for, PEMSS. And these are some of the signs of grief, which we will go into as we get through this presentation. But anticipatory grief is something that's often experienced when a family member or someone who loves another or cares for another person is experiencing grief before that person actually passes away. And this is common when there's a long illness like cancer or any other degenerative disease, dementia, because grief symptoms can show up before someone passes away. So we often were called upon to talk to the people and to give some interventions and work with them through some of the counseling interventions that I'll be explaining to you in this presentation before the person passed away. It was just the body understanding that they were losing somebody, and that grief process started even before someone passed away. Disenfranchised grief, that's things like divorce, job loss, even pet loss, because some people, most people, and I am this way, okay, we have 4 cats and we lost a cat recently, very sadly. Disenfranchised grief is a type of grief that happens when a person doesn't, or society in and of itself doesn't recognize that as a type of grief, but it is a type of grief, which is called disenfranchised grief. But it's real, the symptoms are real, and it's actually there. Collective grief is also known as cumulative grief. This one right here is one we see as clinicians often a lot, because what happens is clients suppress grief and then they lose someone, they suppress grief again and they lose someone, and then it's collected and it passes up over time and adds up over time, and it becomes hard to deal with. So they have delayed grief because they have stayed busy and they've done things to kind of just not deal with their grief, and it's delayed oftentimes. I've seen it delayed for 20 plus years in clients. And then complicated grief often becomes the only mental health diagnosis. It is the only pathology for it, but it's known as prolonged grief disorder in the DSM-5 TR. So that we will discuss how you can qualify for that. But first, I use this in my grief counseling sessions, some of them with children and adults. This is a grief roller coaster, right? And it's something that from a website that I subscribe to called therapistaid.com. And it is very good because it explains that grief is a journey of emotions, and it follows all these twists and turns and ups and downs like that roller coaster. And it can change from day to day. So you can have peace one day and then all the way down has sadness, and it can change, and it's unsettling as this roller coaster depicts. Grief upends people's lives, and clients understand this when you put this picture and you share this in session with them, because they really have a sense of frequent setbacks and being lost after losing a loved one. But like being on a roller coaster, grief is workable if we try to stop controlling the roller coaster, and surrender to the feelings. And we have to feel those feelings, but with support through therapy and with time, most clients eventually get to a better place. Now, as we know, grief is multidimensional. It doesn't live in just one domain. It's all consuming and affects emotions, thoughts, the body, behavior. And as clinicians, we have to be able to recognize these dimensions and avoid mislabeling grief as different pathological or mental health diagnoses. Some common emotional symptoms are deep sadness, yearning, longing, anger, numbness, blunted emotions. Those are all common things. Being scared to love is also something that's common, or scared to care for someone else because they have lost someone significant in their life. And it's something I've seen in practice: anxiety and fear about the future. Sometimes there's even relief that shows up in grief counseling with clients. And you wonder, why is it relief when they're grieving someone? Well, relief often happens when there's been a long illness and there's been a lot of caretaking that had to happen for someone, and their person passed away. And there's a sense of relief, but then there's a sense of guilt, right? And then this can also be the case when their relationship is really complicated, but they still feel issues of loneliness, abandonment, and the intensity of this can fluctuate as well. We often say that grief ebbs and flows like a wave. Grief is like waves, ebbs and flows. And around an anniversary, you often have to prepare a client for this. Also, times like songs, like different smells, different places, the holidays, they often cause grief bursts. And it can be beneficial to prepare a client for these times. Cognitively, in our brains, right? Grief often causes difficulty concentrating, confusion, disorientation, labeled the grief brain. And often there is a preoccupation with the loved one or how the death occurred. I would have cases in the hospice where I did a lot of the clinical counseling work first in grief, where a person would want to see the absolute death records or see the medical records to understand deeply and scientifically how the process occurred. And we often wouldn't let them see those specific records, but we would just kind of bring them to a place of peace about it by explaining it generally and overall. Rumination and what if thinking and the shoulda, coulda, woulda. I've seen that so many times as a grief counselor where I should have done this or I should have done that, and they don't have closure. And there are techniques to work through that with clients. They often question life's meaning. They question their own spiritual beliefs. They're angry with God. You can have people who are really faithful come in as clients, and they're so angry with God for taking their person. Now, these cognitive shifts often mimic symptoms of anxiety or trauma responses. But they are a part of normal and complicated prolonged grieving. So we have to be able to recognize that as clinicians and be able to understand the realms, because we don't want to misdiagnose clients. Behavioral symptoms include social withdrawal, social anxiety, social avoidance, isolation, restlessness, agitation, crying spells, overworking, or distraction seeking. Often we'll see substance use disorders develop from this if people are not dealing with it in therapy. There will be changes in appetite or sleep patterns or engaging in rituals or memorial behaviors, things that eventually become very unhealthy. Somatic symptoms include fatigue or low energy, chest tightness, and heart palpitations. And if someone comes in and they says, I'm having all these heart palpitations, and they have delayed grief, and they don't really consider the fact that they didn't mourn somebody that they love, you might diagnose them with generalized anxiety disorder or panic attacks. And the real root of the issue is the grief. And when you deal with the grief, the panic attacks and the things kind of go away. Other things that can happen somatically include sleep disturbances, headaches, gastrointestinal issues. People might go to the doctor for stomach aches and not understand how it's connected to grief, but it can be. And it doesn't mean that the pain isn't real. It means that the pain is psychosomatic. So it's controlled by the emotions. We have to work with people on those things because the body remembers and often carries the weight of loss. There's a book we read in graduate school called The Body Keeps the Score by Bessel van der Kolk. And I really recommend that and going back to use that and to understand the somatic nature of emotional responses to grief, because it applies here. Often clients with trauma histories have limited emotional expression, and that's one thing we see as well. Now, the only DSM diagnosis for grief is called prolonged grief disorder. When seeing clients who do not meet the criteria, you can choose to use adjustment disorder with depressed mood or anxious mood. That's something that can be used to kind of get past the insurance stuff. It's an F code. And one way to be able to see clients who have recently lost a loved one is using that adjustment disorder diagnosis. Or if they meet the criteria for acute PTSD or acute stress reaction, or major depressive disorder, generalized anxiety disorder, etc. I've used those things before when the loss was too recent to qualify for prolonged grief disorder. Because the criteria for prolonged grief disorder is that the individual experienced the death of someone close to them at least 12 months ago as an adult, and it's 6 months ago for children or adolescents. Since the death, there has to have been an intense yearning or longing for the deceased person, or a preoccupation with thoughts or memories of the deceased. This must be present most days for at least the past month. And the individual must experience at least 3 of the following symptoms: identity disruption, marked sense of disbelief about the death, avoidance of reminders of the loss, an intense emotional pain, that's sadness, guilt, anger, sorrow, difficulty with reintegrating into life. That can be socially, occupationally, in their families, all those areas. Emotional numbness. A lot of times people will shut down their emotions and won't want to feel any emotions after a loss. Also, the feeling that life is meaningless without the person that passed away, without their loved one. Intense loneliness. So it's pretty easy to meet the criteria if you've met the time of it. The disturbance has to cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. And the grief reaction has to be out of proportion or inconsistent with cultural, religious, or age-appropriate norms that we see. So sometimes clients want people to just listen to them. And that is one of the counseling techniques here that we will discuss with prolonged grief. Sometimes people just want someone to listen to them. And the way to do that is supportive reflection. And that allows the client's feelings to be validated. So grief can be very isolating and very confusing. And sometimes having a therapist mirror back to them with empathy, of course, that, hey, you're not alone. Your feelings make sense. This is how you should feel after this kind of loss. For example, a client might come in and say, especially you'll recognize as a clinician, they're dealing with delayed grief. I once had a client that lost someone over 20 years and they had not gone to counseling. And it had been 20 years since the loss. It was a very traumatic loss. And they had all these different pictures and different things in their house. They were isolating themselves. And this client had a fiance that was violently stabbed. And it was a really horrible situation. The person was in prison dealing with it, but this client did not know how to deal with it. So what he did is he just stayed busy, and he ended up with a number of those psychosomatic issues that I talked about and tons of anger. In fact, whenever he called the intake department, he couldn't connect that day to telehealth for some reason, and he ended up cussing everyone out. And I ended up talking to him and getting him connected to it. And we figured out that through his case, he was having those anger spurts, and that's how he was dealing with it. But he ended up having complex PTSD. So grief can actually co-occur with other mental health conditions like complex PTSD, major depression, generalized anxiety. And grief counseling is beneficial because if one of the clients I just described like that comes in and they're able to receive closure and get to a place where they're at peace with their loss, then they're less likely to end up with other mental health disorders. And in fact, one of the things that I always suggest to clients when they're at a place where they're ready to do this, to move on through something where they can remember their lost loved one. And that often happens with maybe volunteering or things like that. In the hospice, 5% of hospice services are government mandated to be provided by a volunteer. So doing things like writing cards, spending time with family members who've lost someone, other things like helping read stories. In the veteran community, we had people who participated in flag salutes for families who were losing someone, or for the client, the patient, when they were passing away. Clients would participate as volunteers to do that. And that is a way, like creating a remembrance to honor the loved one that they lost. But people are not ready to do that right away. So it does take some time. And once they're able to, it can bring immense healing for them. So that's something to think about and consider. When we talk about other grief counseling strategies, this basket question exercise, it's one of my favorites to work with even children, like even adolescents, you can use this one. And you take index cards and you write stuff out, and you cut it and you fold it and put it into a basket. And you shake it up. And when you're sitting there in the session, you have them draw one out at the time. And it has prompts like my favorite memory of my loved one was, or I wish I had said, or they taught me blank, those things like that. Those are amazing counseling prompts. And if you search online, just through Google, they're even available through a website that I love called whatsyourgrief.com. And that is a website that will be in the reference sources, but it was created by social workers And they actually came up with a lot of things. There's a section on there for grievers. There's a section on there for people providing grief therapy and grief counseling. But there are amazing things on there to be found. And another activity to do with adults and children both is a collage. Now, what I've found in practice is that adolescents really like to do this collage exercise with pictures from their phone of their loved one, if they have a smartphone or something like that. That often is where you use 15 to 20 pictures, and you have them either print out the photos and they put them on a poster, or they just do a digital collage with 15 to 20 photos and bring it to the session. And this facilitates them talking about their person. And it's really been beneficial because then you can move into other interventions that we're going to discuss here as well. Narrative therapy is another approach that you can use, and that's for someone who might get into writing. And in sessions, I've seen something like, 7-8 page letters to their loved one. Narrative therapy is great because it invites rich description of both the person lost, the client's life before, during, and after the death. And I often do this, but not at the beginning, because clients are usually coming into grief counseling, they're not ready for this. But I'll have a client write a goodbye letter to their person. And there's prompts online for that as well. I have a couple exercises for what can go in the letter in some grief counseling books. And if you have Amazon Kindle Unlimited, there's grief counseling books for therapists that have these prompts for children and for adults. And for children, you can do memory boxes instead of doing a letter. Maybe they're too young to write, but they can put things in a box that they remembered, right? So that's kind of something to do. These things can then be shared at the burial site, and it provides closure. Or if the person was cremated, they can share it where they scattered the ashes. Legacy conversations is another part of narrative therapy. And it encourages a client to look at what their person they lost left behind in them, like stories and traits, special values. So for myself, when I was under my master's program and doing the clinical work in grief counseling, my grandmother suffered from dementia. And this little personal aside to tell you, and she really, really, really throughout my life defined faith for me. My mom was 16 when she was born, or when I was born rather. And my grandmother served kind of like that mother figure for me. And one of the things that she told me is, when I questioned my faith at one point in life, is, can you see faith? I would tell her, I can't see faith. It's a hard concept to understand. And she goes, April, can you see the wind? And I said, no, I can't see the wind. Can't see the wind, right? But she says, can you see what the wind does? And I was like, well, yes, I can see what the wind does. I can see the leaves when they blow. I can see if strong winds come through and it destroys something. Well, faith is really like that, she said. She said, faith is like the wind. You can't see it, but you can see the results of it. My own faith journey started and was strengthened through that experience. So a lot of metaphors that you can use with grief too as well when you're writing those prompts for clients is that grief feels like blank, or it's as if my world turned gray. That's a lot of people will describe that. For example, a grieving daughter might say, I'm not the same without my mom. Then the therapist might ask, well, what would your mom say about the woman you're becoming now? And lastly, many clients benefit from individual therapy as well as support groups that offer activities, psychoeducation, and a chance to be around others in the same age group or have lost a partner or a special loved one. In the past, I have witnessed profound post-traumatic growth with group therapy in addition to individual therapy. When clients go and participate because they truly are able to see that they're not alone, that's one thing, that is a way that they have dealt with their grief. Now, next, we'll look at some special populations that we must be mindful of in in working with grief counseling. So special populations include children and adolescents, neurodivergent clients, those with ADHD, those with other neurodevelopmental disorders, clients with developmental delays, older populations, and those from marginalized communities. And your approaches have to be different. So if your client is one of these different special populations, look up interventions for those. Now, there is a video that I often use with loss of life partners with the older population, and I'm going to share that with you. There's other videos on YouTube, though, for children about grief that explains it using cartoons, and that's a really good approach because it's developmentally appropriate. I recommend using those in session, and there's shorter ones available, so you can search for those. But this is one that I use often in working with those clients of older populations.
When we're grieving a profound loss, we often say we're heartbroken, but it might be more accurate to call it brain broken, given the role the brain plays in grief. As your brain adjusts to the loss of someone you love, you might feel numb, depressed, or foggy. But moving through the stages of grief is natural and healthy. It helps you process your loss and begin to move forward over time. This is Your Brain On, where we explore how the world affects our brains and ourselves. The experience of grief is twofold: the immediate acute pain of the loss, and the months afterward as you mourn. The loss of someone meaningful functions as a stressor, triggering the pituitary gland at the base of the brain to produce adrenocorticotrophin, or ACTH. ACTH sends a signal to the adrenal gland to release cortisone, a stress hormone. Unlike, say, a temporary threat, grief is an intense, persistent stressor, so your body remains flooded with cortisone. That can cause your immune system to falter, making you feel run down. This is likely why some bereaved spouses fall ill soon after their partner dies. Even if the death of your loved one was expected, the actual event can still feel like a shock to the system. In the short term, a traumatized brain is bottom-heavy, meaning primitive areas, including the fear center, are overactive, adding to feelings of stress and despair. Meanwhile, higher cortical areas of the brain are underactive, like the anterior cingulate cortex, which helps regulate emotion. You may find it difficult to let go of minor annoyances or experience symptoms like increased heart rate for several minutes after you're startled. However, over time, the initial shock of the loss typically gives way to a deep sadness or depression as you continue to mourn. Depression can cause widespread changes across several parts of the brain, including the amygdala, which regulates sleep behavior and mood, and the hippocampus, which processes memory and regulates stress hormones. These changes disrupt core functions of our bodies and minds. As you grieve, you may find yourself sleeping too little or too much, forgetting things, or trapped in a brain fog. These feelings are difficult, but the acute pain doesn't last forever. Eventually, the sadness begins to lift at least a little bit, and then you may move on to feelings of anger or guilt before slowly moving toward acceptance of the loss. Experts agree that bereaved follow their own individual timelines, but in general, this 3-stage process usually takes about a year. There are steps you can take to feel better as you go through the grieving process. Talk therapy can be a major help. This might be group bereavement meetings or cognitive behavioral therapy, which can redirect negative thoughts. Aerobic exercise can improve mood, memory, and thought processing. Talking with friends about the person you lost can be a great comfort too. Studies show long-term grief actually activates neurons in the reward centers of the brain. And recalling the time spent with those who have died reminds us that the memories still live on.
So this is a video that I really like to use with older populations. And that's because this is something we saw a lot, and we had a huge support group back at the hospice where I was. So the last thing that we really need to be aware of as clinicians is ethics, boundaries, and self-care. So grief can uncover trauma, suicidality, and as we talked about earlier, prolonged grief disorder most often requires specific clinical skills to work with, and along with trauma-informed care and advanced grief training. So we must, as clinicians, ensure that we're practicing within our training and scope of practice and licensure. Sometimes we need to refer out when a client needs psychiatric intervention or medication. If you begin to feel that way as a therapist, that the regular counseling is not working. or if you don't have the training to deal with delayed grief or cumulative grief or traumatic losses. So those are times to be aware of this, especially. Grief often arises in interconnected communities, and there's a risk of boundary confusion when this happens. That's in like faith groups, military communities, things like that. There's a risk of boundary confusion, like I said, and blurred lines of confidentiality. What happens is, an example of this is maybe you're asked to be a therapist for someone who's grieving, who you shared a relationship. Maybe the relationship was different, but you still had some kind of relationship with someone you knew, and you attended the funeral and you knew someone else at the funeral, and then you were asked to be a grief counselor for that person. Well, you really can't do that without risking countertransference and transference and boundary confusion. And it can be an ethical violation. So you really want to be aware of that if you are looking at taking on a grief client. Also, common places, another example of that is, say you have children and they go to the same school and you know the parents, and maybe the parents lost their parents or something like that. That can also be an issue too, because dual relationships become an issue. So those also in most codes of ethics kind of mention that you want to be aware of that. So as clinicians, we have to be transparent about our potential conflicts of interest. Something else to be aware of is that therapists, we're not immune from grief, right? So as a clinician, we have to be aware that our own grief might surface, and there's a risk of countertransference when you have a client whose story mirrors your own. Another sign of this occurring is when you feel stuck as a clinician. You might feel completely stuck or overly emotional during a time, like right after the sessions, or you become avoidant, or you start over-identifying, become too emotionally involved with it. That can happen with other clinical areas as well. Unacknowledged countertransference can really cloud your clinical judgment. So you have to shift the focus back from that and make sure that you're aware that you're not engaging in those cases, because it can cause harm to a client and it can create burnout to you as a clinician. And say the client has already confided in you and developed this relationship and this rapport with you, it can re-traumatize a client pretty badly if you then realize, oh, wait, I can't work with that client because their story is a lot like my own, and it's bringing up all these feelings for me that I didn't realize that would happen with this case. So one of the biggest things that also happens is compassion fatigue. Providing grief counseling on a consistent, everyday basis can raise a risk of compassion fatigue if clinicians are not engaging in self-care practices. So it is crucial to be aware of the differences between compassion fatigue and vicarious resilience when we want to serve clients. Compassion fatigue includes feelings like emotional depletion, loss of empathy, some cynicism can be thrown in there, loss of boundaries, poor boundaries. But vicarious resilience is what we really want to strive for as grief therapists, to develop feelings such as emotional inspiration and develop feelings that there's a purpose and that we have deepened gratitude and meaning and strengthened perspectives. Again, be aware of compassion fatigue creeping in, because it's very, very sneaky, and you can become irritable. Again, you can dread sessions. You can wish that they were canceling the session. You could have emotional numbing. So as a clinician, we do not want to do harm to clients who have already had so much emotional harm when dealing with grief. Lastly, just as we teach our clients to engage in self-care practices, we want to engage in self-care as well as clinicians. We must. And it can be things like after heavy sessions, back-to-back sessions, because working with grieving clients and families does wear on a person. And there is no lie about that. There are some days after doing that work, One of my coping strategies was get in my car and blast music. Maybe that's what you do. Or maybe some self-compassion exercises or some self-compassion practices might be that you take a short walk after, or you engage in your own prayer or spiritual practice. Maybe you light a candle, or you take a walk, things like that. But it is crucial, if you're going to serve this population, that you have a quiet moment and you continue, however you do that, to be healthy in your own body, mind, and soul. Because serving grieving clients is a tough thing, but it can also be really rewarding. And I happen to love it very much. Here are some resources for further study if you're interested. Understanding the grief brain and understanding that amygdala hijack that was kind of alluded to in the video for older adults. Neurodivergent grief. That's a very specialized area. Also a website that I mentioned before, whatsyourgrief.com, that was created by social workers. It has that section for clients and therapists in their videos. And then working with grieving children. There's all kinds of strategies for that on this UC Davis website. And then working with older and aging populations. So they grieve differently, just like neurodivergent and children. So thank you for today. And I hope that you have learned a lot from this presentation.